So imaging to assist left atrial appendage closure, TE or ICE. The steps that are there in a LA appendage closure are as follows. There is a femoral venous puncture, and followed by there is a transseptal puncture, and then you have the LA sizing and device deployment. These are the various devices that are available. Plugs being the first generation, Watchman being a prototype. Pacifiers, Amulet is what we generally use. And we are not going to be really talking about ligation devices. So that's the structure of the left atrial appendage. And all right, so you have an ostium, you have a neck, and you have lobes, which may be one or many. You have the left superior pulmonary vein, and you have the left circumflex artery. Now, when we image the left atrial appendage, these are all things that we need to bear in mind. I'll show you the case of an elderly lady who was a hypertensive with atrial fibrillation on oral anticoagulation, who was admitted with an intracranial bleed. First and foremost, the sizing. Before that, we rule out left atrial appendage thrombus. So here we see a windsock kind of left atrial appendage. That's the circumflex, that's the ostium, the Coumadin ridge, left superior pulmonary vein, a bit of pericardial effusion pre-existing, and we find that there is no clot. So one of the main functions that we do transesophagally is to assess the shape, whether there are any bends in this, how many lobes there are. And that may have an implication on the kind of device. However, nowadays it doesn't really matter much. But traditionally, from the first generation on, this was something which was important to know. So these are the various morphologies which we might be familiar with. This has an implication on both the landing zone as well as the implantation axis. So the landing zone and the implantation axis. And what we see here is the presence of multiple lobes, and one of the lobe has been missed, the Watchman device sitting somewhere else. And these are examples of malalignment. We need to assess the left atrial appendage in multiple views, 0, 45, 90, 135 degrees. So what an easy way to do it is to first go to 45 degrees and then to 90 degrees, as has been shown here. Many of our echo machines have this biplane mode or X-plane. So what we can see here, 45 plus 90, what we can see here is the 135 degrees. And similarly, if we were to biplane this at 90, we will get 0 degrees, which is sometimes a little more difficult to get from by itself. So with this biplane function, we can easily assess the multiple views that are needed. So often for sizing, just 45 with a biplane and the measurements can be taken, as has been shown here for the Amulet device. So from the ostium, we go about 10 to 12 centimeters into the cavity, and then there we size it. So here we have measured 21 millimeters, and likewise at 135 degrees, we go 12 millimeters inside, and we've got 21 millimeters. This is a 3D image, never mind. So this showing the Coumadin ridge, the left atrial appendage, the left superior pulmonary vein, and the measurement taken, again around 21 millimeters. So this is a crude way of doing it. A more refined way would be to use a multiplane reconstruction. And this is how we have measured it, and that also comes to 21 millimeters. Now, sizing may be a little different for different devices, like for the Watchman and the Amulet, as has been shown here. The next step is the transseptal puncture. And what we need, the two views again we need is the 45-degree view. Aorta is anterior, we need to go a little posterior. And this is the bicaval view. This is the SVC here and the IVC there with the eustachian valve. We go away from the SVC. So it's an infero-posterior puncture that is needed for a left atrial appendage closure. So again, the aortic valve, it is away from the aortic valve. It is away from the aortic valve. This green is where we are supposed to puncture. And this is the bicaval view showing the SVC here, IVC. So away from the SVC. So away from the SVC is where we need to puncture. So that is 45 degrees and that is 90-degree bicable view. And for different interventions, the puncture sites may be different. Now, why is it like this? Because the left atrial appendage, as we know, is an anterior structure. It has an anterior bend. So we need to come from behind forwards. And that's the reason why we need to puncture it in that fashion. The final step is the device deployment itself. And this is the RAO caudal view, which corresponds to 135 degrees. The RAO cranial view, which corresponds to 45 degrees. So the working view is 45 degrees with a biplane, and we can do everything with that single view. So this is, I've just turned it around to make it look like this view here. And what I've shown here is that there is no leak. And this is the final result showing the amulet device in place. It is stable. And that is the on-fast 3D view showing the device in place. This is the largest investigation evaluating TE and ICE in the setting of left atrial appendage occlusion. And this was done in more than 1,000 patients with AF at high risk for bleed with oral anticoagulation. It was done over a period of a year. And this study, it had more than 900 patients on whom the closure was guided by TE. And around 130 patients, it was guided by ICE. That is 12% of the patients. The risk factor profile was comparable at baseline. There were 16 ICE operators from 13 sites in Europe. 8 of the operators used ICE in more than 50% of their cases. So 8 out of the 16 used ICE in more than 50% of the cases. And the remaining 8 operators used TE for the majority of the cases. The experience of the implanters also varied from something like 10 to 120 ICE-guided LA appendage occlusion procedures. And for those undergoing TE, it was mainly general anesthesia, but almost 1/3 of the patients were done with conscious sedation. So meaning to say that if the case selection is good, then we can use conscious sedation also with TE. The Abbott catheters and the ultrasound machine was used, and a double femoral venous puncture was used, obviously, for the ICE catheter. The end result was the same whether it was TE or ICE at 1 year. However, the procedure duration, the total fluoroscopic time, and the contrast were all more with ICE use. Now, this is, bear in mind, these are extremely experienced operators, many of them using, having done close to 100 procedures. So the procedure duration, something like more than 7 minutes, fluoroscopic time around 5 minutes more, contrast nearly 45 ml more with the use of ICE. What is also interesting to note is that those who used ICE predominantly, that is more than 50% of their cases, their procedure duration was almost half of those who used TE predominantly. So there is a message there that the more familiar we are with the modality, the better that modality becomes. Now look at certain things which are relevant to ICE use. So when we put the catheter, we are in the right atrium. And what we have shown here in the same patient that we implanted is the left atrial appendage occlusion device here. So because these are high frequency probes, it's almost impossible to view this particular appendage from the right atrium. You could go into the pulmonary artery and try to view it from there. But that maneuvering is going to be challenging in many cases, and you may still not get good images. So obviously you need to do a transseptal puncture and go into the left atrium to view the left atrial appendage device and to guide the. So that means multiple punctures. That means interference with the delivery cable and noise, which you will have to navigate. So that is to kind of summarize the different positions that you could take. The best position would be, however, the left atrium, but that means the transseptal puncture. Now, as I mentioned, going with a single puncture, you can have interference from the delivery catheter system, and hence a double puncture means puncturing it, the IAS twice for the ICE catheter. So, in the final analysis, T is low cost. It is a familiar thing, and in most big centers, in the Indian context, we may be doing something like 1,000 Ts a year. The LA appendage is very easy to visualize. Using biplane modality, you can very easily see it in multiple views in a very short period of time. ICE, on the other hand, is a single-use catheter. It's costly. It cannot, image quality goes down as we use it for a longer period of time. And of course, in this very ideal kind of study, I mentioned and I showed how it consumes more contrast, the procedure duration is longer, fluoroscopic time is longer, and in inexperienced hands, the time taken may be almost twice that of doing a TE. So in conclusion, T will still guide left atrial appendage occlusion in our context. Literature and evidence still reflects the best case scenario for ICE. The real world experience is definitely different. Thank you.